Hello, thank you to those who are joining. We are just about to be joined by Katie Noble, who is a clinical embryologist at the Agora Fertility Clinic in Brighton. So we'll be able to connect in a sec and talk all about day 3 versus day 5 blastocysts, transfers, how many to transfer, how many embryos to transfer, PGD testing, PGT, and every other question you have. So please feel free to ask questions. That's what the Agora are here to do and to help with. She should be joining any second, so hopefully we can reconnect this time. Thank you to everyone who sent questions in advance. Let me see whether she's here. Okay, here we go.
Oh,
Hi Katie, how are you?
I do apologise for that. I thought I was being organised by using my laptop. So sorry for that.
Don't worry. These things happen. Always technical stuff at the worst of times, isn't it?
Always, always.
Anyway, it's lovely to be connected. I've given a brief introduction about what we're going to be covering today, which I know is on top of people's minds. Just could you start by introducing yourself and the Agora, and then we can start taking questions and talking about embryology.
Yeah, absolutely. So I am a clinical embryologist at the Agora, which means I am based in the lab doing all things lab related with the sperm, eggs and embryos. So it's the embryologist that looks after those for you whilst you're having treatment with us at the clinic. The Agora is based in Hove, Brighton and Hove, and yeah, we'll be happy to answer any questions that you might have.
Great. So I think one of the top questions that you probably hear as well, and loads of people come to our platform asking, is what does success look like for day 3 versus day 5 or even day 6 embryo? And why as an embryologist would you choose each of those scenarios?
Yeah, so at the Agora we do both day 3 and day 5 transfers. The difference between the two is not necessarily to do with embryo quality. So going to day 5 is actually a selection tool for the embryologist to be able to more reliably pick the best embryo for transfer. So we pick the embryos based on a grading. So they're graded on day 3 and they can be graded on day 5.
Mm-hmm.
Now we use different grading schemes on day 3 and day 5 because the embryos look very different at those 2 stages of development. Now, more often than not, when we look at a group of embryos on day 3, they quite often look quite similar to one another. So at that point, especially as we normally aim for a single embryo transfer, so just transferring one embryo back to our patient, at that point on day 3, it's quite difficult for us to reliably pick the best embryo for pregnancy. So for transfer, sorry, and by that I mean the embryo with the most potential for pregnancy based on the grading, because they look quite similar to one another. Now with embryo development, there's a big jump between day 3 and day 5. So we don't expect all embryos to make it to day 5. But as I said, that acts as a selection tool for the embryologist to be able to pick the embryo by day 5 with the most potential for a pregnancy.
And why do you sometimes choose to do a day 3 embryo transfer?
So we would choose to do a day 3 transfer if we can already pick the best embryo for transfer. So if we look at a cohort of embryos, so a group of embryos, and maybe because some of the other embryos aren't doing quite so well, we can already pick the best one for transfer, then there's actually no benefit to waiting to day 5 because it is just that selection of picking the best embryo for transfer. And if that's already obvious by day 3, then there's no benefit to waiting until day 5.
Would you say on the whole day 5 transfers have a higher success rate than day 3?
Statistically they do, but it's not because they're day 5, it's just because we can more reliably pick the best embryo for transfer. So as I said, if we're doing a day 3 transfer and we can easily pick the best one, then the success rate is just as good.
Okay.
Sometimes we do a day 3 when unfortunately none of the embryos look top quality and we still have to pick the best one from that group. So that is sometimes why the day 3 success rate appears lower than the day 5, but generally it's not about the day of transfer that affects the success rate. It's about our ability to pick the best embryo for transfer.
I remember being really upset that I was told I was having a day 3 embryo transfer because it didn't look like many were going to make it to day 5. and I
Yeah.
almost had made myself believe that the round was going to be unsuccessful before I even got the result. It actually wasn't successful, that round. However, would you advise patients not to go off and Google and worry about these things straight after transfer?
Absolutely. You will quite understandably have a lot of questions. If you can't think of your questions at the time when you're with us in clinic, then you can access us either by phone, email, or we've got a messaging app if you think of your questions afterwards. But we do recommend that you ask us rather than Google, because the information can be quite misleading. So if you look at the statistics, it would suggest that day 5 was better for success, but that's only because of our ability to pick the best one for transfer, not because day 3 is detrimental. So it's good to just speak to one of us so that we can explain that to you in the context of your treatment cycle as well. So we can work out what's best for you to give you the best chance of success.
And for patients having treatment at the Agora, how often do you speak, or does the nurse, whoever it is, give the results or update the patient during that time?
So in terms of embryo development, on the day of egg collection, once the eggs have been collected and once the sperm has been prepared so that we've got the best sperm from the semen sample, and once the patient has woken up from her sedation, if she's a little bit woozy, then one of the embryologists will come and speak to either the individual or the couple having treatment, and let them know how it's gone. So speak about egg number, and also the quality of the sperm. And then we will talk them through what happens next, so what the next steps are in the lab and when to expect to hear from us next. So after that conversation on the day of egg collection, the next time there would be an embryo update would be with the fertilization check, which is the very next morning. So we can check for signs of fertilization in the eggs by about 17 hours post insemination, so post the egg and the sperm meeting. Mm-hmm. So at that point we check. So we check the very next morning and then we'll update you then. At that point, we'll let you know how many are fertilized and can explain if there was any abnormal fertilization or if the fertilization rate was as expected. And we also let the patient know then when to expect their embryo transfer. So whether that be a day 3 or a day 5, we'll book that in for them then, let them know when to expect that. If it is a day 5 transfer, we would still check the embryos on day 3 and update the patient then as well. So they'd get an update day 3 of development, and then again on the morning of day 5 before the embryo transfer, so that we can discuss embryo quality in terms of suitability for transfer and potentially for freezing of any surplus top quality embryos.
Mm-hmm. Amazing.
So there's a few points of contact. But
Great.
Patients can call us in between or message us in between on the app if they've got any questions. It's a lot to take on board, so if there's anything that comes to them later in the evening, then they can message us anytime.
Great. And I'm sure this is a question that you get asked a lot as well. How much choice do patients get in terms of transferring one embryo or 2?
So we do have to be strict. So the reason we are strict with embryo transfer numbers, so single versus double, is that we really do have to minimize the number of multiple pregnancies we have, so twins or triplets. And that is based on the safety of the mother and also any unborn babies that are successfully conceived. So we have to have a policy that means in at least the first 2 embryo transfers for all of our patients, we recommend a single embryo transfer. Now that can be up for discussion based on embryo quality, but it absolutely would be our strict guidance and advice that we do just do the single embryo transfer for those first 2.
Does it make a difference about age of the woman as well?
It's definitely a consideration. Age quite often correlates with embryo quality. So unfortunately, as women age, our embryo quality tends to be a little bit lower. So that does come into the conversation. And the patient can have a conversation with the embryologist, the doctor who'll be doing the transfer, and we can discuss all of the contributing factors. But we do have to bear in mind that any single embryo transferred can still divide after that time to become 2 separate embryos. So if you do a single transfer, you may end up with 1 healthy baby, you may end up with 2 babies, or unfortunately no babies in some circumstances. So we really do have to be very strict with that when we bear in mind how many embryos we are happy to transfer.
Okay. We've had quite a few questions come in, so I'm just going to ask these whilst people are live, and then we have a bit more to cover. So I'm just trying to find them. Thoughts on why such a high percentage of embryos are abnormal? Is there any way that lifestyle choices impact that? And also thoughts on metabolomics?
Oh, metabolomics. Metabolomics is the study of what the embryos metabolize, so the energy substrates they need to continue in their development. So metabolomics is looking at the study of the media, which is the fluid that the embryos are kept in, and what it is the embryos take from that media to help them with their development. Now, commercially available culture media, which is the fluid the embryos live in, is designed as such that all of the proteins, all of the energy substrates that the embryos need for development are available in that media, and the embryo can pick and choose as to what it wants. There's nothing clinically applicable with metabolomics at the moment that can be applied to embryo selection for transfer. So metabolomics is very much something which is in research stages at the moment and is not clinically applicable.
Interesting, thank you. Another question, thoughts on thoughts on unsung human growth hormones to improve embryo development? Or using, sorry, that's what you meant.
Of using, sorry, what was the
human
first
growth
one?
hormones to improve embryo development?
That's not something we have looked into hugely at Agora, because the literature at the moment is very undecided. Everything we do is scientifically driven. Mm-hmm. So if we make any changes to our protocols and our practices, it's based on there being sufficient amounts of data for us to practice, and also we have to abide by regulation from the HFEA as to treatments which they say are licensed for use in treatment. So any decisions we would make would be based on scientific data, but that's not something that we are currently looking into.
Okay, thank you. Any tips for increasing embryo transfer success?
Embryo transfer success, really, there's lots of contributing factors. We know that the quality of the embryo, so the grade of the embryo, is a huge contributing factor. We also know that you can have an A-grade embryo on day 5 and still not, unfortunately, achieve success. And that is when it comes down to the intrinsic abnormality of the genetics of the embryo. Mm-hmm. So in terms of creating good quality embryos, we need good quality eggs, we need good quality sperm. So it's the lifestyle factors that contribute to both of those things, which can directly impact on embryo quality, which is then a contributing factor to success of embryo transfer. Lifestyle factors for sperm in particular need to be in place for at least 3 months before the ejaculate is produced for use in treatment, because that's the life cycle of the sperm. So it takes 3 months to produce the sperm that are then ejaculated on treatment day. So any lifestyle changes need to be in place at least 3 months before the day of treatment.
Okay, that's good to know. Thank you. And this leads on from that. Have there been any developments in technology that can help with the development of embryos and success rates?
So in recent years, there's been the introduction of time-lapse incubation, so using incubators like Embryoscope. Now, they are incubators that provide exactly the same conditions as our standard incubators, which are all designed to mimic what's happening in the female reproductive system. So they're the right temperature, they're the right gas concentration, they're nice and dark. So as I said, everything mimics the female body. Now, the difference between standard incubation and time-lapse incubation is that the time-lapse incubator can take a picture every 10 to 12 minutes. So we can then watch back a video of that embryo's development. Now that part of the technology allows us to see if the embryo has done anything peculiar. So ordinarily with standard incubation, we just get a snapshot into the development of the embryo. So we see it at fertilization, we see it on day 3, we see it on day 5. We don't see how it gets between those stages. So it could be that it's done something a little bit peculiar in between. And in that case, we can actually use the videos that are captured as a deselection tool. So if we've got 2 embryos which look identical on day 5, or more or less identical, we can look back at their development and we can see actually maybe one of them wasn't quite on the right timeline, or maybe it did something a bit peculiar, so we'd then choose the other one over that one. So again, that's part of a selection tool. The other benefit to time-lapse incubation is that we don't need to remove the embryos from the incubator, so from the environment they're happy in, to be able to assess them. So because they stay in the incubation chamber and we assess the videos, we don't have to disrupt their environment. Whereas standard incubators, they have to be physically removed from the incubator to be looked at under the microscope to be able to make that assessment.
Okay.
So it's an uninterrupted culture, so uninterrupted environment is a bonus of that technology, which has become a lot more commonly used over the last few years.
Amazing. And would it be yourself as an embryologist, or would it be at the Agora, or would it be a specialist who would decide which embryo to transfer?
If you were having treatment with us at the Agora, that would be the embryologist would choose which embryo, because we've made the assessment about the embryo quality. So we would use our grading system on both day 3 and day 5, if we did a day 5 embryo transfer, to pick which embryo had the most potential for pregnancy based on those grading parameters.
That's another thing, isn't it, where you hear a grade at the beginning before the transfer, and then you have that grade ingrained in your mind whilst you're waiting during the 2-week grade. How much should people focus on the grade of their embryo?
If we are transferring an embryo back to you, it's because that embryo is viable and it has potential for pregnancy. The grading system, because we don't know what's going on inside the embryo, so going back to those genetic abnormalities, the grading system really can only provide an indicator of the embryo's potential for pregnancy. It's relatively reliable, so it's good to know the grade. The grading helps the embryologist differentiate between the embryos for us to be able to pick the best one for transfer. But because we still don't know what's going on inside the embryo, it never can be a guarantee that because you've got an A grade embryo, that will lead to a healthy pregnancy. So it's useful. It's not, however, a guarantee in terms of the grading and the potential for pregnancy.
Makes complete sense. Thank you for elaborating on that.
You're right.
Someone has asked, and I don't know whether this is a question for you or a specialist, but less IVF for fertility medication, can that improve the quality of the embryo? Is there a correlation between how much stimulation you've had and how the embryos turn out?
Not directly. Your stimulation will be tailored for you by the clinician. So that's not something really the embryologist can comment on. So your medication and your stimulation will be based on why you're having treatment with us in the first place, and also how you respond to that medication or how you responded in a previous cycle. Because the stimulation is tailored for you by the clinician, I can't really comment in terms of embryo quality, because it's specific to each individual.
Yeah, that makes complete sense. Thank you. If you've had previous single embryo transfers, would you consider a double transfer? You've already said, haven't you, 2 rounds at the Agora of single embryo transfers before that would be considered, dependent on the situation.
Yeah, that is the general rule. As I said, it also depends on embryo quality, but that is the hard and fast rule, really.
Okay, brilliant, thank you. And someone has just touched on a question I was going to ask you now anyway. Success rates between fresh and frozen embryo transfers, how do they differ?
So at the Agora, we freeze the top quality embryos because statistics have shown over the years that embryos that are not top quality do not survive the freeze and the thaw process. So when we grade the embryos on day 5 of development, which is the stage at which we can freeze them, we look for them to be the stage of development called a blastocyst, which is where the embryo should be by that time. And within that, they also have to be top quality. So they can be graded from A through to C at that stage. Embryos that are A or B can be frozen. C grade embryos, statistically, they just don't like the process. They're not robust enough to survive that freeze and then come out the other side with the thaw. So at the Agora, the thaw survival rate, so the percentage of embryos that survive being frozen and thawed again for transfer, is up above 95%. And then so that's 95% of frozen embryos survive the thaw process. And then when we looked at our pregnancy rates between fresh and frozen transfers, actually there was no statistical significance in the difference. So same pregnancy rate for fresh and frozen. They just have the extra hurdle of surviving the thaw when you do the frozen transfer.
Am I right in thinking, again, this might be for a clinician, that some like to have a break for the woman if she's had her eggs removed before doing the transfer anyway, so that's another plus for freezing?
So that would really be a question for a clinician. There is research into whether or not we should freeze all embryos and do all frozen embryo transfers rather than fresh, but the data from that was relatively inconclusive.
Okay.
So in terms of individuals wanting a gap or needing a gap in between egg collection and transfer, that would be for the clinician to decide.
Absolutely. And what about IVF versus ICSI? Who benefits from either of those procedures?
Yeah, so IVF is where we prepare the sperm, and when it's of good quality, we can then just put the prepared sample with just the good quality sperm in a dish with the eggs, and then we leave them to it. Yep. So that it's very much like natural conception, where the sperm that are viable will travel towards the eggs in the dish, and whichever is the strongest sperm will be able to successfully fertilize each of the eggs. Whereas ICSI is when we inject an individual sperm into eggs that are mature in their development and hope for fertilization that way. Now ICSI is an added step, an added procedure, and we need to justify the use of ICSI. So we wouldn't just routinely use ICSI for everyone because it's not necessary for everyone. So ICSI is used when we've got a sperm sample which doesn't meet our criteria for being considered optimal. So we make an assessment of the sperm on the day of egg collection. So we look at the number of sperm, the concentration, the motility of the sperm, which is the movement, and also the normal forms or morphology, which is the shape of the sperm. Now, if they are below certain threshold values, then it would be our recommendation that we did ICSI to try and prevent low or failed fertilization, which is a possibility doing the IVF when the sperm sample isn't optimal. So ICSI generally is used in treatment cycles when the sperm on the day of egg collection is not optimal.
Would that be the case, for example, for frozen donor sperm?
It shouldn't be. So donors, when they freeze sperm to become a sperm donor, they have to have sperm of a certain quality. So they have to have good quality sperm in order to become a donor. There's a very stringent screening process for donors in terms of their hormones and their semen quality before they are frozen and are used as donors. So in theory, all donor samples should thaw and should be good enough for use in IVF. So we should be able to prepare the sample. So we eliminate the bad sperm, which is normal in every sample. Fresh ejaculate, frozen ejaculate, partner, donor, is very normal to have immotile sperm in there. So the processing that we do eliminates those from the sample. And we see that slightly higher number of immotile sperm in frozen samples because not all the sperm survive the freeze and the thaw. That's very normal. But with donor samples, it should be a good enough quality that we can thaw the sample, eliminate the immotile, and still have enough motile sperm to proceed with IVF insemination.
That's amazing. Because when I had IVF with donor sperm, we had ICSI, and that was quite a few years ago. I don't know if that's something that's changed over time, but it's...
In my time as an embryologist, freezing of sperm does seem to have gotten better. So just anecdotally, the freezing of sperm, we seem to have higher survival of sperm these days. It's not a guarantee with donor sperm, unfortunately, but that is what we aim for. We just don't know, however, how well the sample will thaw until it's done. So until the day of egg collection, we don't know how that exact ejaculate from that exact donor will thaw. So we just have to wait and see in terms of the resulting quality.
Yeah, okay, that makes complete sense.
Yeah.
And what about PGT? Do you do testing on all embryos?
So it's not something we currently do at the Agora. We are hoping to work towards that in the future. There is evidence to suggest that testing embryos for aneuploidy, which is the abnormal number of chromosomes in an embryo, is present in lots of embryos. So in theory, you could biopsy day 5 embryos and freeze them. You would then be able to know which of the embryos had the right amount of chromosomes, and you could then transfer only embryos which had the right number of chromosomes. So really the technique works towards quicker time to pregnancy, because although you've got the same embryos, you won't waste a transfer on transferring an embryo which doesn't have the right amount of chromosomes. So it's something we're looking into, but it's not something that we can currently offer at the Agora.
That's really interesting to hear. Thank you so much. Well, thank you so much, Katie, for your time. I hope that everyone's questions have been answered. We've had a flurry of questions, so I appreciate everyone asking away. Is there anything else you think people should know before you go? We've touched on most things, haven't we?
We have touched on most things. My biggest piece of advice is, if you're not happy with the information you've been provided, maybe because you think it's not good news, then don't lose faith, because we absolutely do see pregnancies with the lower quality embryos. So do not lose faith. And if you've got any questions, just please go to your clinical team, your embryologist, your doctors, your nurses, rather than Google, because although it's really helpful sometimes to have that information, it doesn't always apply to yourself, and everyone's treatment cycle is different. So we would like to provide information that is going to help you.
Yeah, fantastic. Thank you so much. Now, for anyone who doesn't know the team at the Agora, they're very, very friendly. They're based in Brighton. The Agora took part in our Fertility Clinics versus COVID campaign earlier this year, where, we're delighted to say that the lesbian couple who were successful with a free round of IVF at the Agora, due to being impacted by finances and COVID, are now 13 weeks pregnant. So that's wonderful news, and we're so grateful for everything that you do for the community, your patients, and to support our readers. So thank you so much.
It's our pleasure. It's a privilege.
So if anyone wants to speak to the Agora, feel free to DM us, or you can speak to the Agora directly. But thank you everyone for joining today, and thank you so much, Katie.
Thank you.
Okay, bye everyone. Bye.